Good morning, good afternoon, and good evening all. And thank you for attending our NETEC H5N1 Town Hall updates for frontline staff. NETEC's mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S., with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. The mission is achieved through the collaborative efforts of 13 regional emerging special pathogens treatment centers across the country, with more than 100 industry leaders representing a range of healthcare specialties, from infectious disease clinicians to emergency medical services leaders who share their expertise across NETEC's 15 national work groups and 9 task forces. NETEC leverages the knowledge and experience of its regional partners to produce timely and innovative educational resources, provide technical consulting and assistance, build a national special pathogens research infrastructure, and convene global partners. I'm really excited to introduce our amazing group of subject matter experts who are joining us from around the country today. So this is an overview of what we're going to be talking about. My name is Anna Yaffe, and I'm an emergency physician at Emory University, and so a member of the frontline staff as well. We'll first hear a little bit about updates on the current state of infection prevention and control recommendations for H5N1, and then laboratory considerations for H5N1. And then we'll move into the majority of our conversation, which will be panelist discussion. I'm joined today by Dr. Allison Galdis, who currently serves as the Assistant Medical Director of Infection Prevention at the University of Minnesota Medical Center. Vicki Herrera, who is a research coordinator at the University of Nebraska Medical Center in the field of infectious diseases and bioaerosols, and who serves as the lead for NETEC's laboratory work group. Dr. Alex Isakoff, who is the founding executive director of the Office of Critical Event Preparedness and Response and professor of emergency medicine at Emory University. He serves as Emory's section of pre-hospital and disaster medicine director, and also as the co-lead for NETEC's EMS work group. Dr. Saira Madad is the chief biopreparedness officer for New York City Health and Hospitals. Dr. Erica Shenoy is a chief of infection control for Massachusetts General Brigham Healthcare System, an infectious diseases physician at Massachusetts General Hospital, where she serves as the medical director of the Regional Emerging Special Pathogens Treatment Center. And finally, last but not least, Adam Sorensen is a nurse educator for Denver Health's HIT team, which staffs the Denver Health Biocontainment Unit. I'm so excited to hear from these subject matter experts, all the nuances of preparedness and response for H5N1. First, I will turn it over to Dr. Erica Shenoy, who's going to provide updates on current state and infection prevention and control recommendations for H5N1.
Thanks so much, Anna, and welcome everyone. This looks like a really large crowd and a great crowd to be able to have an excellent conversation. As Anna mentioned, we're just going to start with a few slides, brief overview, so that we're all starting the conversation on the same page, and then we'll move into the discussion part. So background, so we're all on the same page about H5N1 or novel influenza. Throughout the session, we're probably just going to refer to it as H5N1 for short. But this is a virus that has been circulating at low levels in animals for decades. And by decades, I mean actual decades. The first recognition of this virus is actually back in 1959 in a chicken outbreak in Scotland. But it didn't really get to major attention until the mid-90s, when there was an outbreak in 1997 in Hong Kong, and there were about 18 human cases associated with that, but no sustained human-to-human transmission. And so for many years, this has been tracked by public health authorities around the world. And then most recently in 2022, the beginning of a very large outbreak here in the United States among both domestic and wild birds. There was one human case, and in fact, this was an asymptomatic case. Fast forward a couple years, in 2024, this year, the outbreak has expanded to include dairy cattle. So not just poultry, but dairy cattle. And there have been 4 associated human cases. And this is as of last Friday when all of this gets updated. And then in this year as well, 9 poultry associated human cases. So in total in the United States since 2022, There have been 14, of which 9 have been confirmed to be H5N1, but we assume the rest are H5N1. And to put that in perspective, since the start of recognition of human cases in 1997, there have been over 900 cases over this long period. In the US, while there are poultry flocks and dairy herds across many states that have been identified to have H5N1, the human cases have been from just 3 states, Colorado, Michigan, and Texas. So the overall risk as assessed at this time to the public is low. And here I'm just giving 4 kind of approaches, and there's links to this. And so you all have probably already visited these, but you may visit again. The way that public health authorities are putting this all together in terms of being able to make that assessment that the risk is low. So these are various ways of looking at the data. So the first part is actual H5N1 testing on influenza A samples. And when I checked last week, for the week ending on August 3rd, over 39,000 samples have been tested nationally using a protocol that would have detected H5N1, and there were no detections. So I think that's very reassuring and one way to look at the extent to which H5N1 might be circulating. They're also looking at clinical laboratory trends for influenza A, and over the course of the summer, when we know we have lower amounts of influenza A circulating, there have been no unusual trends at all levels. Similarly, when we look at trends in emergency department visits, and also looking this year for the first time at wastewater surveillance related to this, there's very little evidence that there is that there's H5N1 out there that we are currently not detecting at any significant level. So I think that's all very reassuring. And at this point, the outbreak really is about animals, and the few human cases related to direct exposure to those animals, so high-risk exposures, and with no evidence at this point of any sustained human-to-human transmission. So turning less from what the risk is right now, the CDC has developed what's called an influenza risk assessment tool that was developed to think in the future, to think about what could be the risk of influenza A viruses that are currently not really circulating in people, such as H5N1, to lead to a pandemic. The most recent report was published just last week and includes data collected and analysis through June 26. So it's not including the most recent Colorado cases in humans. And what this assessment does is it takes all the data available, they have experts who review this, and then they make an assessment about the potential impact to public health, as well as the risk of emergence of a pandemic-associated virus. And the assessment that is really considered to be low is based on the fact that, as we discussed, that this is mostly an animal health issue at this point. Human infections are rare, and the viruses at this point are not well adapted for person-to-person spread. And that most of the past human infections have occurred following close, unprotected contact with sick or dead birds, and more recently related to dairy cow exposure. This is an image from that report, and I think it's a really good visual to kind of think of where we are in terms of, could this become a pandemic, which is obviously always on the minds of public health leaders. On the y-axis, you have the potential public impact, so increasing public impact. On the y-axis, on the x-axis, you're going from what's the risk of emergence. And the factors that go into this are detailed in the report, but they're looking at all sorts of things related to what we know about the transmission, the immunity in the general population, and they put it all together and they basically scale these various viruses. And the ones that are highlighted are the H5N1s. And so this is really at the moderate level in terms of future pandemic risk. Now we're going to turn briefly to the infection prevention and control, which I love. It's my favorite sort of thing to think about because it's really powerful, and we're using the identify, isolate, and inform framework. And here we need to figure out ways that we can identify at the first point of entry whether an individual presenting with acute respiratory illness could be at risk because they have a relevant exposure history in the 10 days prior to symptom onset. Now, in the symptoms, Most of these symptoms are very similar to seasonal influenza or other respiratory viruses. They will come with acute respiratory illness. But I just add in here, remember conjunctivitis, which has been seen in recent cases as one of the presenting signs and symptoms, rarely in isolation. So likely with other respiratory illness symptoms that you're very familiar with. The exposure is the part that we have to think about ways to educate and help the frontline identify these, because these are not, in some places in the country, not the most common exposures. So contact with potentially infected, sick or dead birds, livestock, or other animals. And you can see the sorts of activities that might be included there. Direct contact with water or surfaces contaminated with feces, unpasteurized raw milk, dairy products, or parts of these potentially infected animals, or prolonged exposure to potentially infected birds or other animals in a confined space. And I think the emphasis there is on prolonged exposure. At the moment that you identify that you might have a patient who meets these criteria, you're going to implement standard contact and airborne precautions. I highlight here that standard includes hand hygiene, of course, and all the rest of standard precautions, including respiratory etiquette. The PPE for the personal protective equipment for our healthcare personnel, gloves and gown, eye protection, and respiratory protection, all those components of contact and airborne precautions. The patient should be masked outside the room wearing a face mask, and especially for travel or transport around a healthcare facility. And patient placement ideally is an airborne infection isolation room or a negative pressure room, but if it's not available, a standard private room with the door closed is appropriate. And I've included links here to the interim recommendations from the CDC, which have a lot of excellent detail in them. Next slide. And then this part is inform. So this is one of the things that you get to the identify part, you get to the isolate part, and then it's so important to talk to the right people. I include two parts of internal communication. One is to make sure that everyone caring for this patient or interacting with the patient understands that the patient is under evaluation. And this can be signage on the door, something in the electronic record, but you really need to make sure that the group caring and interacting with the patient understands that this is on the radar so that they can use the appropriate personal protective equipment and implement the correct isolation. The other internal contact is your local infection control contacts, and you'll know who they are in your facility, and they are there to help you and sort out next steps. And they are often the individuals who will be liaising directly with public health authorities who are going to provide additional guidance, including coordination of testing if indicated. And then I'll turn to my colleague, I think, to talk about testing. Thanks so much.
Thank you so much, Erica. I'm going to turn the floor over to Vicky Herrera, who's going to talk about laboratory considerations for H5N1.
Great, thank you so much. Next slide, please. So continuing on what Erica was saying, informing the laboratory is also a very important component. The electronic records may not always transfer over to the laboratory, so just make sure that the laboratory is in those conversations for informing. Currently, the FDA-cleared influenza diagnostic tests that are available to most laboratories do not specifically subtype H5 or anything with avian influenza origin. However, they will give you a positive result for influenza A. So you may see an influenza A positive or an unsubtypable result. Right now, the public health laboratories are the ones that have the ability to subtype the H5 specific influenzas. CDC is working on increasing the testing capabilities nationwide, but for right now, contact your public health laboratories if there is a high suspicion or if you get an unsubtypable. They will be able to direct you in either sending it to them or to a laboratory that is close that is able to do that. Specimens should be collected ideally within 7 days. The sooner the better for laboratory specimens. Make sure that they are placed in a viral transport media. And again, reach out to your public health laboratories as to the appropriate types of media that they are able to accept. And due to the current outbreak in the specimen types that they have been seen, the public health labs have received approval to run the conjunctival fluids. But multiple swabs may be required. They may require both those eye swabs and a respiratory specimen as well. So again, just make sure that you contact your public health labs for the current requirements that they need. And as you can see on the resource here, the CDC has an excellent resource on how to collect those eye swabs. Shipping is always a big question. In June of this year, the Select Agent and Toxin Division issued an exemption for H5 avian influenza viruses so that they are exempt from the select agent rules for a period of 3 years. This does not actually mean that they are no longer a select agent. It just means that they are able to not follow all of the select agent rules in order to quickly respond should there become a larger outbreak that involves human. The diagnostic specimens, however, can be shipped as a category B. This does not include cultures. Cultures are still considered a category A when shipping. And as always, cultures are not recommended in the clinical laboratories and really should be avoided because that is such a high viral titer and some of those rules. So avoid those whenever possible. Respiratory and conjunctival specimens may have a little higher viral titers and should be treated with caution. So consider wearing enhanced PPE when dealing with those specimens when H5 is suspected, such as eye protection and maybe an N95. Do your risk assessment in your lab to determine if there are additional standards, precautions that need to be elevated when dealing with these specimens, but utilize a biosafety cabinet whenever possible and avoid aerosolizing procedures if possible in the laboratory as well. And I will turn it over to Anna.
Thank you so much, Vicki. We're now into our town hall period. So we did solicit questions from all of our participants when you registered for the webinar. So we'll be addressing some of those questions today, but I also encourage you to ask questions using the Q&A box at the bottom of your screen. We'd prefer that questions go into the Q&A box so that we can respond to some of those live and also answer questions real time for you. So please definitely, I see you're already doing a great job of using the Q&A box, so please keep that up. And otherwise, we will move into our discussion. So I invite all of our panelists to come on your screen and we can have a bit of a discussion. I'm really excited, particularly because we have panelists from all across the country. And so certainly there may be some regional differences that may be applicable to some of our panelists. So to start off the conversation, I do have a question for Erica. Some of our participants were wondering how H5N1 specifically differs from, let's say, seasonal influenza viruses.
Thanks, Anna. And I agree, great questions already coming in through the chat. So I think the way to think of it is on a couple levels. First, very obviously exposure. So H5N1 clearly still has a very obvious exposure link that we talked about, whereas seasonal influenza, it's circulating out there in terms of exposure risk, and there's person-to-person transmission with seasonal flu, so that's a big difference. I think symptom-wise, we kind of alluded to this, they generally, seem to have similar symptoms, although the cases that have been in the United States to date, as they have been reported, have been very mild to the point where there have been, as far as I'm aware, no reported hospitalizations, including there have been some asymptomatic cases. And then there's that conjunctivitis feature, which hence the testing that's been described. So I think from the symptom perspective, like many upper respiratory type infections, they can present with a wide spectrum, and that seems pretty similar. Another kind of way to think about this is, what is the case fatality rate? That's something that we obviously are concerned about from a clinical and planning perspective. And in the over 900 cases reported, of human cases reported since 1997, overall, the case fatality rate reported is around 50%. And that's very different than what we're seeing in the small number of cases that we've had before, but that's the number in the literature, and there's more to learn about that and whether or not it really is 50%. From the infection prevention and control perspective, obviously the stuff that I just talked about is not what you would apply to seasonal influenza. And the rationale for that is threefold. One is that, again, the case fatality rate is differs as far as we can tell. The level of immunity that is out there in the population really would be very little to none, I would think, for H5N1, but there's more studies on that. And I think the idea is that there's very few cases out there. And so we're adding higher levels of isolation and use of PPE that we would normally not do for seasonal influenza. We'll probably get into treatment later on, but right now, as far as is known, all the H5N1 that has been identified as far as can be assessed is treatable using the standard treatment that we would use for seasonal influenza, which is oseltamivir. So I think those are kind of like the similarities and differences to think about the two of them.
Thank you so much, Erica. I know that kind of thinking about how to prepare for potential H5N1 patients is something that a lot of frontline facilities are facing right now. So I'm hoping that our panelists can have a discussion about kind of what your facility is doing and how frontline facilities can best prepare for patients with H5N1. And maybe we can have Syra kick us off.
Thank you. So a couple of things that I'll mention, and if we can go to slide 38, that would be great. So Erica shared a really wonderful presentation on identify, isolate, and inform, and those are really the key steps as we talk about being able to identify patients, isolate them, and inform appropriate, internal and external contacts if we're suspecting H5N1. She's also going to show a really great, electronic medical record system approach for screening, and so I won't get into that. But what I will like to share is just how is our health system, New York City Health and Hospitals, really preparing for H5N1. So what you see on the screen here is this is one of our testing algorithms for H5N1, and we're collaborating very closely with our local health department. And we basically have three pathways here. The first is we're leveraging our virtual express care. And for those that have known exposure to H5N1s that the local health department has identified, we would utilize our virtual express care, and then we would designate certain hospitals within our health system to receive patients for testing. The testing is going to actually be broken down by a clinical risk assessment that we've put together. And this clinical risk assessment is broken down into, are we suspecting human-to-human transmission, which, as you've heard earlier, has not occurred? Are we suspecting animal-to-human transmission? And based on some of those core questions, we would send the patient to either Bellevue, which has our biocontainment unit, which isn't necessarily required for H5N1, but since it's an asset within our health system, we would utilize it for those initial cases. And then if it's animal to human exposure that we're suspecting, it would be to our other designated EDs that we have discussed. So we have partnered with our public health authorities to develop this algorithm. And the last pathway that you see here is just a walk-in patient to any of our emergency departments, and how we would go about initially screening, identifying these patients, isolating them, and then moving on to testing. So this is something that we have recently finalized, and we're working on just education on this. The other way that we're just maintaining kind of a state of readiness and preparing, our frontline health system is by ongoing situation reports. And so within my department and my team, we are developing, on an ad hoc basis, these sit reps on H5N1 that goes out to about 300 to 400 health system leaders internally. And it talks a little bit about what is, the local context. What are we seeing locally in New York City? Luckily, we obviously haven't seen any human cases. What are we seeing in New York State, across the nation, and internationally? So it's about a 2 to 3 page situation report, and we update it on an as needed basis, depending on, what the national picture looks like. But it gives a good snapshot of what's happening, and it really tells health system leaders, what do we need to do, and are we changing our preparedness posture? And then one of the things we also have as an asset to, helping our health system with screening is really developing additional resources. And while, the CDC website is amazing and is really rich with a lot of content, for frontline staff, oftentimes, you need something quick, easy, fast, and something that's maybe 1 or 2 pages of what do you do? So we developed this fact sheet, and we've actually developed these fact sheets for a number of different special pathogens. And we developed this for H5N1. And it really details, the whole identify, isolate, inform, signs and symptoms, who to contact, PPE and other infection prevention and control precautions, and the like, and who to call. So this is something that we have developed, a few months ago. We've been educating and training on it. It's posted on our intranet site and the like. Next slide, please. I'll talk about this in another question, so I'll hand it back to you.
I don't know. Oh, Allison, yeah, if you want to talk about what you're doing in your region for preparedness.
Yeah, one thing I wanted to underscore that Saira mentioned is the value in close contact and collaboration with human health and also veterinary health authorities. In Minnesota, we are a heavily agricultural region, and our health authorities, both in human health and veterinary health, have been confronting H5N1 actually in poultry since 2022 in our state. So I think it's important for frontline facilities to designate a person or persons to sort of understand what are the processes that those state health entities are practicing. For example, our human and veterinary health authorities work very closely together. So our Department of Health is closely aligned with our Board of Animal Health, understands the current state of testing in various facilities, and our public health authorities actually track individuals who have exposure on farms where cases in animals have been detected. So I think that that knowledge is important to understand so that a facility is aware of how cases might be directed to their front door. In our facility, we have incorporated very similar strategies in terms of healthcare worker education, having that available on the intranet, both the characteristics of the disease, epidemiologic risk factors, and then crucially, information about whom to call when you want to test.
Anna, I'd be happy to share. Saira alluded, and Allison as well, to a lot of the tools, and all of us, I think, are kind of making up similar tools to educate our clinicians. We've additionally done some building in our EPIC record, and I'm happy to share some screenshots if that would be helpful, looking at slide 31. So what we're about to see is when patients enter an emergency department and they're getting some initial triage, this is a travel symptom and exposure screening tool that we've had in place for probably over 5 years or so. It's asking about travel, and we were we're not sure what to do about this because the travel here with the H5N1 outbreak is not going to be as relevant as, say, international travel. But for every patient, there's a travel question. There are symptoms that are asked, yes, no buttons to make it as easy as possible for the front line to capture these. And what we've done for H5N1 is we added just one new symptom, which is supposed to get at the conjunctivitis one. You can see that. Do you have new eye, red eye, or irritation? And then in the additional screening section, which is generally meant for respiratory virus screening and has generally been focused on COVID, we ask about that contact. And this was just actually updated in our record yesterday. This is a tool that is, because it's required documentation, there's very high compliance. And then based on the answers, you can build in decision support to kind of alert a clinician that they should think about H5N1. And you'll see that on the next screen. So if you answered yes to either fever, feverish, respiratory symptoms, or that new symptom of red eye irritation, and that exposure is elicited, and we use 30 days just to make it easy for the front line to ask that question, you can see on the next slide that there will be an alert that comes to a clinician, and it will say, here are your immediate steps for patient isolation. Here's a link for your resources. And those resources look very similar to what Saira showed in terms of the background that we give our clinicians. It prompts them to order the isolation, and then it directs them to another tool that the provider is going to use to actually get into the nitty-gritty and decide if this person actually meets criteria for additional evaluation. And the next screenshot just shows that additional evaluation. And what this is it's kind of an all HCID or all high consequence infectious infectious disease decision support system. In this case, it's pre-selected novel influenza because of what was just put into the travel and symptom exposure screening. It asked them a couple of questions about conjunctivitis. You can see at the bottom of that right screen, there's some questions about exposure. And here's where you're getting into the 10-day piece. That first question was like anybody in the last month. It's the easiest to ask when someone hits the door, but you really want to get into those details to figure out if they're plausibly within the incubation period. And at the end of that, it says, yes, you need to pursue and you're going to work with infection control to do the next steps. And that's all I have on the visuals there. But any way you do it, I think it's going to be targeted to both your catchment area. So Allison's catchment area is very different than up here in, the Boston and, Northeast region. So some of these may not actually make sense because they may fire too much for your frontline clinician. So that's something to consider.
Yeah, I'll just dovetail. So in our health system, we have acute and ambulatory care facilities that are really statewide. We have 9 hospitals and over 100 ambulatory care facilities, and they are both in urban and also very rural settings. So it was challenging for us to identify a set of screening questions that would be specific because of the proportion of individuals who have occupational agriculture exposure, in addition to more recreational agricultural exposure, although recent data suggests that recreational agricultural exposure, so agricultural exhibitions, which are sort of a cultural phenomenon, at least in the upper Midwest, would probably have a lower risk. So currently, our screening is based at the front, at check-in, is really based on symptoms. And we rely on clinicians, nurses, and providers to perform that nuanced occupational history.
Allison, are you using the electronic medical record to assist that?
So we also have had symptom and international travel screening for at least a year. In terms of prompts to introduce questions around occupational history, we have not built those in automatically, but they're available electronically should a provider grow concerned. There's an area where they can go to review epidemiologic risk factors and the clinical manifestations of H5N1.
I'm also wondering if anyone has any particular strategies or approaches to accounting for patients who have non-English language preference. I know, of course, some of these patients may be having occupational risk in particular. I don't know if anyone has encountered that in your frontline screening.
I will say, I think that's a challenge. Currently, our frontline screening, apart from interpreters who are frequently used and encouraged to assist the evaluation of persons whose first language is not English, we don't have any electronic health record tools to assist the screening. I will say, however, again, sort of leaning on our human and agricultural health authorities, there's been a lot of outreach, fortunately, both within producers and also workers who are doing the day-to-day tasks on farms. So I think that's a key element, but I think that will be an element that we can improve on is tailoring our hospital and clinic-based tools to meet the needs of non-English speakers.
I was just going to add, Allison, I think you're spot on. This is a real challenge. I'm glad to hear about all that outreach. I think we have thought about this in a couple ways. One, the use of interpreters has expanded so much. Clinically, I think I'm on service right now. I'm using it in like half of my patients. We have iPads available. Whether or not that's happening at the front entry because of so much that's going on in our busy emergency rooms, I think that can be a challenge. But that's where we fall back on standard precautions, respiratory etiquette, ensuring that some of those basic communications that we have to patients are using visuals that are easy to understand, that we have masks, hand hygiene, tissues, those sorts of things available in places like waiting rooms, urgent cares, because even if there is a delay to identification, standard precautions goes a long, long way towards reducing the risk of transmission in your facility.
I just want to remind our participants that you can use the Q&A function to submit your questions. And if you have submitted a question, it may have been answered in the Q&A function by one of our subject matter experts. So definitely check back and see if it has been. And then you can also upvote questions using the thumbs up sign in the open Q&A in case you want to kind of reinforce that that's a question that you want answered. One thing that I am seeing a lot of in these questions is about aerosol generating procedures, PPE, kind of what to wear when you're first seeing a patient who we don't know a diagnosis yet. Adam, I wonder if you might a bit more about the type of isolation and PPE we should be using, particularly in the emergency department.
Yeah, thank you, Anna. As Erica mentioned, the PPE recommendation is going to be a gown, gloves, N95 or another type of respirator, and then your eye protection. You can also, if you're more familiar with, or if your standard practice is using, say, Kappa or PAPR, that's also something you can go ahead and choose to use. For any suspected patient or confirmed patient, I always recommend that level of PPE. It's always easier to back off of PPE based off of your findings or diagnosis than to add on your PPE. So you want to start with your respirator, and if the patient turns out not to have influenza or H5N1, you can back off if it's something that doesn't indicate a respirator. And then also to call out for our agricultural workers, the CDC does have recommended PPE for those individuals, and that includes shoe covers or boot covers, a gown, and then over that gown is going to be a like a butcher gown. And then they also call out a head or a hairnet or head cover on top of the mentioned PPE. So that's also something, if as a healthcare worker, the stance is if you want to put on, say, a head cover, that is totally fine. It might be over the amount of PPE recommended, but it's something that you can choose to do. And then I would defer to some other people to talk about aerosolized generating procedures. I know there's studies out there for heated high flow and some other ones that suggest it can be aerosolized, but it's not, from what I have read, conclusive, depending on the settings of the heated high flow.
I can jump in with lab a little bit. Lab is kind of a special little place in that we do procedures where we are actually generating aerosols based on some of the tests that we're doing. So as Adam had said, you can always step down. So if there is a suspect, it's best to do your risk assessment and do your higher level first until you find out more information. And if it's negative or that patient doesn't have as high a risk, you can step that down. So again, we have a special circumstance in the lab where some of those procedures actually do generate aerosols. So just keep that in mind when you're performing stuff and utilize your engineering controls whenever possible.
Perfect. Thank you, Adam and Vicki, for that. I think there's a lot of also questions about sort of like post-exposure monitoring for healthcare workers, for poultry and occupational health exposures, and then in the community. Is there any literature or guidance on how long people should be monitored, how they should be monitored?
The CDC has published guidance for healthcare workers in a human healthcare environment, if they have confirmed exposure to a human case, the recommendation is for quarantine or for that healthcare worker to isolate absent a critical work shortage. And there is a pathway for return if a human healthcare worker is exposed but asymptomatic, similar to what we've seen for other virus infections. I cannot speak as specifically around recommendations for agricultural workers. What I have seen is that there is close symptom tracking. I have not observed work exclusions for individuals who are in the agricultural industry. I think it is important to just recognize that the detection of H5N1 certainly has implications for the economics of an agricultural producer and can lead to, financial and emotional stress. So I think that is not entirely clear. However, at least in Minnesota, as I mentioned previously, there's if there is a detection on a farm, there is active interviews and tracking of individuals. I don't know the time period. I think it depends on the duration of exposure and how long since last exposure.
Thank you so much for that. Was wondering how at your facilities you're training your staff to prepare for H5N1. So of course, these screening, such as what you're doing at your facility, Allison, requires some staff knowledge and kind of awareness. What are you doing to bring everybody up to speed?
Yeah, so it's been a challenge. Passive education is the most feasible, but rarely the most ideal, but has the opportunity to reach a lot of our healthcare workers. So we've had email blasts, we have webpage dedicated to infection prevention, and then within that intranet page, we have specific content that's related to H5N1. I think it really does require frequent reminders to staff that in addition to all of the symptoms and exposures that should float to the top of their attention, that we're dealing with this virus, and providing periodic situational updates, I think is important. And even when those situational updates reflect a low number or zero number of cases, it reminds providers that this is not currently a threat, but a potential threat.
Erica, Syra, Adam, have you done any healthcare staff education?
I'll say very similar to what Allison said. Much of this is passive and just making sure that when people are looking for the information, it is the most up to date, it is digestible. I know we could do better. Like Allison was saying, there are so many things that are competing for our frontline staff attention that it's really difficult, I would say, to make sure that they're all up to speed as we would want them to be. On the other hand, things are changing day to day. And so having and repeating and trying to inculcate the identify, isolate, inform framework kind of across the board, I think is probably a more resilient solution. And then providing the additional detail, the granularity that they might need a step removed from that once the identification isolation has happened can be, I think, a more resilient, because it's pretty possible that 2 months from now, we could be thinking that there is a different or a more important exposure risk. And to re-educate thousands and thousands and thousands of our healthcare workers on the details of that, I think is just very hard to do. And I'm really looking to hear if anybody has other solutions for this. It's very challenging.
So I will say for health and hospitals, there's two ways that we continuously update and educate our workforce. I think the first is, as I mentioned, we have these situation reports that go out to key leaders and frontline personnel on a as needed basis. And it includes some of our internal collateral resources we made, like our quick action guide and the like, but it gives an ongoing update when there's a significant change in either the epidemiology or the cases and the like. So that's one way. The other way is my program actually hosts a monthly system special pathogens briefing meeting that's open to, all 45,000 staff members within health and hospitals. And in that, kind of 1 hour-ish meeting, we provide updates on a number of different infectious disease threats that we're monitoring as a team. And H5N1 is included in that. So we give any updates and any changes, any resources that have either been updated or changed. And as you can imagine, obviously with H5N1, the epidemiology does continue to shift a little bit. So we do continue to update our assets and resources. And so on that monthly call, we continue to update them on any specific changes.
Vicki, is there anything in terms of healthcare worker education that you would recommend in terms of communication to the lab when there's patient samples?
Direct communication with the laboratory is always helpful. Sometimes that electronic record doesn't transfer to the lab. They have to open special places depending on what system they're using in order to see that. And they don't always do that when they have a high throughput lab. So just direct communication, I think, is the most helpful. That way, kind of give them a heads up, and that way you can communicate also getting the results back quicker.
Yeah, Anna, I'd like to jump in there too. On the other end, what we've seen is our laboratorians and our lab personnel are up to date and very knowledgeable about the change of if this is a flu A that's on subtypable, knowing the process, but also doing the communication back to the providers on what the next steps are and what's going to happen with those specimen collections, or is there more specimens needing to be collected, things of that nature, to then send to the State Department. The other thing I'd like to point out too is with the education and with staff, we do very similar things to what all is mentioned, but within our pediatric emergency department, it is good to call out too, not just asking the patient, but also the parents or the guardians, what is their occupation, or do they also have an exposure history, which just for that population is very important for potentially why that pediatric patient could have a disease like H5N1 or their exposure if they have chickens, things like that at home.
Absolutely. Alex, in terms of EMS preparedness, is this something that EMS should be screening for? Should there be communication between EMS and the hospital? Or these discussions that are taking?
Hey, Anna. So good question. What I would say is that, EMS should always sort of have some situational awareness about the patients that they're going to assess and would maybe have need to transport. I think, EMS personnel clearly get education and training on implementing standard precautions. And that's going to be very helpful. Clearly, if they're interacting with a patient that has cough or other respiratory symptoms, fever, it's recommended that they put a face covering or face mask on the patient, in addition to wearing at least a face mask and gloves and everything else associated with standard precautions to prevent exposure to potentially infectious bodily fluids. For EMS personnel that might be working in areas where there are dairy farms, where there may be local reports of infected herds in their service area, or similarly, if they are able to get a little history from the patient after implementing standard precautions that would give them concern that the patient might be infected with H5N1 because they worked around sick poultry or birds, defeathering them or culling them or some other occupational exposure that would put them at potentially high risk for becoming infected with H5N1. In that case, they should do two things. They should implement the new recommendations around personal protective equipment and a hierarchy of controls. So they should escalate to an N95 respirator, fit tested, NIOSH approved, in addition to eye protection or face covering, of course, gloves and a gown, if that's available. And you mentioned communication with the emergency department or where they may be transporting the patient. That's really important too. So, if EMS personnel actually are suspecting that the patient might have an H5N1 infection because of their signs and symptoms, because of, let's say, their occupational exposure, then they should communicate that to whomever they're bringing the patient to increase their awareness of that, so that the receiving personnel can apply the appropriate personal protective ensembles, implement the right hierarchy of controls, afford rapid isolation of that patient to a private room with a closed door, an airborne isolation room, as opposed to triage to the waiting room, or sitting in the ambulance bay waiting to be assessed, or something else. And so that communication with the receiving team is really important.
Thank you, Alex. I'm wondering about prevention measures for H5N1. So Allison, are there, or Erica, is there a vaccine for H5N1? Can we use the seasonal vaccine? What kind of prevention measures are there?
So the seasonal vaccine will not protect against H5N1. It protects against the viruses that are included in it, but it's very important to get your seasonal flu vaccine to prevent infection and severe disease. So those vaccines, I think, are coming out now. It's the time to start thinking ahead and making appointments to get you and your family vaccinated. There are H5N1s under development. I'm not a vaccinologist, but I've been reading and tracking what the CDC is doing with respect to that. And so there is a plan to be prepared should we need to have a targeted vaccine for H5N1.
But of course, very important to get your seasonal flu vaccine as best practice and to protect you from what we will expect to see circulating more person to person. I think we have time for just one more question. I really appreciate this dialogue as we've been over the last hour. I've learned a lot, and I hope our participants have as well. I'm wondering in terms of surge planning. So Syra, I don't know, is H5N1 something that we should be thinking about in terms of respiratory surge, or is this kind of go into more general planning?
So I would certainly put it into the general planning bucket for a few reasons. I mean, first is Erica pointed out earlier in her presentation, there's no sustained human-to-human transmission. And so we're not certainly at that point yet where we would start seeing large-scale outbreaks. But I think being in the preparedness posture is always important. And so there's a couple of things that, I could share that we're doing within health and hospitals. If we can bring up slide 41. So the first is, we're actually developing an incident response guide specific for H5N1. This includes, if we start seeing smaller number of cases, which is, much more plausible right now. There's still, it's still just animal to human transmission. But if we start seeing something more significant, or if we do start seeing, human to human and then sustained human to human transmission, how does that escalate from there, and how does that change our overall planning? So our incident response guide is considering some of those specific scenarios and building out some action items. We actually did a tabletop exercise on H5N1 back in May of 2023 within our health system, with a number of different departments like emergency department, ICU, communications and marketing, infection prevention and control, and the like. And there's a number of different kind of, considerations, recommendations, and areas for improvement that we've noted. One is creating an incident response guide, for our planning purposes. And so that's what's going to really help us as we continue to plan forward. And hopefully it doesn't get to that point, but it's always good to have some sort of a plan in place before you get to that particular trigger point or threshold. And so we're working on a number, of different improvement areas that we've noted within our tabletop exercise.
Thank you so much for sharing that. Thank you to all of our subject matter experts for your dialogue, your expertise, your resource sharing during the last hour. I really appreciate your time. I do want to take a couple minutes to share a few NETEC resources. And just so everyone knows, again, the resources that were shared today in terms of the PDF, the video, and the other resource list will be available in the NETEC resource library, so that will be something that's available to you. But also, NETEC offers other support. So you can submit a technical support service request at netec.org or by emailing info@netec.org. And you can submit a request online to start an evaluation like the SPORSA, and you can contact us anytime for questions, support, or other services. We also have a lot of different resources on the website that are available for healthcare professionals, frontline and assessment facilities, as well as EMS agencies, and really anyone that might encounter a special pathogen in your work. So you can send questions again to the info@netec.org or visit the website for more information. We also have a lot of social presence, so please connect with us by following us on social media and signing up for our e-newsletter so you'll know about upcoming trainings, webinars, and new courses for continuing education credit. We do have a NETEC podcast, Transmission Interrupted, which is available on all major listening platforms for informative and insightful conversations with guest subject matter experts about special pathogens. We also have the resource library where you can find education, training, and the latest research on all stages of preparedness and response. And this does include specific types of resources such as what has been shared today, so you can see what's available at your facility. Thank you so much for your participation today. We really enjoyed all your questions and look forward to connecting with you in the future.